So thank you very much for coming out this evening on a Monday evening. I know most people are probably dreading the start of their week, so I do appreciate you coming out to this special WACOG Keynote speaker series tonight. We're going to be talking tonight on the clinical management of triple negative breast cancer. And we're very lucky to have Professor Adam Brufsky, who's come all the way from Pittsburgh in the United States. But before we begin, I just wanted to do a quick acknowledgement of country. So in the spirit of deepening relations, I'd like to acknowledge the traditional custodians and owners of the land, the Whadjuk people of the Noongar Nation, and recognise their continuing connection to the land, waters and community. I also pay my respect to their elders and extend that respect to Aboriginal peoples living and working in this area. I'd also like to acknowledge our sponsors this evening. We don't have a picture of them, actually, we normally do, but thank you to WACOG, as well as the Department of Health of WA, Gilead, who are the primary sponsor of this evening, as well as Roche, Lilly, and Novartis Pharmaceuticals. Just like to remind you all that, as usual with the WACOG event, at the end of the meeting, an electronic evaluation form will be sent out to you all for feedback. Please complete this, as it does assist us in planning future events, particularly presentations such as this where we have a keynote speaker. It'd be very good to hear your feedback on what sort of things you found beneficial and what sort of things you'd like to see in the future. So please allow me to introduce Professor Adam Brufsky. He's got a very, very impressive bio, so just bear with me as I get through this. So Adam Brufsky is a professor of medicine at the University of Pittsburgh School of Medicine. He currently directs the Comprehensive Breast Cancer Center and Women's Cancer Center at the UPMC Magee Women's Hospital in Pittsburgh. He also serves as the Associate Director for Strategic Initiatives for the UPMC Hillman Cancer Center in Pittsburgh. He earned his MD and his PhD in developmental biology at the University of Connecticut, and then completed a fellowship in medical oncology and bone marrow transplantation at the Dana-Farber Institute in Boston, Massachusetts. He's an active member of ASCO and the American Association for Cancer Research, and he's authored or co-authored more than 300 abstracts and research articles in leading journals, including New England Journal of Medicine, Journal of Clinical Investigation, Journal of Clinical Oncology, and Lancet Oncology. He's also principal investigator on several research grants funded by the National Institutes of Health, as well as many others. So if you can please all put a hand together in introducing Professor Brufsky.
So thanks a lot for that really nice introduction. And I'm still feeling the jet lag. I got here Saturday night, and it didn't hit me yesterday, but it hit me today. So if I happen to keel over in the middle of the talk, someone can revive me, I hope. So anyway, I'm going to talk tonight about metastatic triple negative breast cancer and really review kind of where we were 5 years ago and kind of where we are now. And then maybe toward the end of the talk, kind of give an idea of where we're going in the future. I guess in the announcement, we were going to do some ESMO breast, but there was not a ton at ESMO breast. Actually, what we talked about in the question and answer session, if you'd like. I think there was something at EBCC in more early stage disease that maybe we can talk about in terms of triple negative breast cancer, but we're really going to focus on metastatic triple negative breast cancer tonight. So these are just my competing interests. So again, in the United States, triple negative breast cancer is about 15% of all breast cancers. Generally, it's younger age. Generally, it's more common in African-American women in the United States. It's high grade. There's a higher risk for visceral metastatic disease. The vast majority of triple negative breast cancers are the basal subtype, and we're going to get into that in a minute, what the subtypes are. I think the most common mutation, like for almost all cancers, is P53. However, interestingly enough, the PI3 kinase pathway is activated in about 10 to 20% actually of all triple negative breast cancer. We'll get into that in a minute because I think it gets to be very important. And it's more likely to be associated with BRCA genes than the other breast cancer. Probably 15 to 20% of all triple negative breast cancer, at least in the United States, is associated with one of the genes, either BRCA1, 2, PALB2, or some of the other genes that we may talk about a little later. Now, it's really interesting. This is data from Jennifer Pietenpaul's lab, who until very recently was the Cancer Center Director at Vanderbilt. She's still an active investigator. But what was found very early on, well, not very early on, but more than about 15 years ago, is that when you do expression profiling, RNA expression profiling of triple negative breast cancer, actually they divided the cancer really in an unsupervised classification, divided itself into these various subtypes. The first was basal-like, which was cell cycle DNA repair and proliferation. Basal 2 was more PI3 kinase mutated. I think it was EGFR, PI3 kinase. There's an immune modulatory subtype. There was kind of this M subtype, motility subtype, more involved with EMT transitions. And then finally, there was what's called a luminal androgen receptor subtype. It was kind of like an estrogen receptor positive breast cancer, but it was driven by male sex hormones, testosterone. And I think, when this initially happened, we were all really excited because we said, wow, we can maybe direct therapy to a particular subtype. And some of us still try to do that. But again, it's it got a little bit mixed up, a little bit mixed. And now we have this basal immune activated, basal immune suppressed, mesenchymal, and luminal AR subtype. And you can have a therapeutic strategy, obviously, for each one. Maybe for the immunotherapeutic, the immune activated subtype, we could try immunotherapy, various immune checkpoint inhibitors. That was the idea here. This immune therapy subtype was PD-L1 positive. Maybe the basal immune suppressed subtype could be BRCA activated or kind of DNA damage repair deficient, and maybe we do PARP inhibitors. There in this basal and mesenchymal subtype, there are a lot of antigens that we can use: TROP2, HER2, HER3, LIV1, and potentially antibody drug conjugates could be used in that. And interestingly enough, what we found, and it's not in this diagram, is that it turns out that BRCA positive triple negative breast cancer and PI3 kinase mTOR activated triple negative breast cancer really are segregated, believe it or not. They're kind of two different at least at a molecular level, they behave as two different kind of tumors. And that becomes important because there are trials of AKT inhibitors. There's a trial Capitello 290 that was completed about 2 years ago. And it was a trial of paclitaxel with or without capivasertib, which is an AKT inhibitor. And the trial was not closed for futility. A similar trial done by Roche with ipatasertib was. So it's really interesting. The fact the trial's been open for 2 years and hasn't been said it's futile tells you there's a signal there of some sort. Whether it's statistically significant or not, we don't know. Hopefully we'll find out in the not too distant future, and may have something else that we could potentially use for metastatic triple negative breast cancer. But again, these ADC targets don't need to be oncogenic drivers. These subtypes are not quite aligned. I mean, you do get some mixture of immune activation and, say, DNA repair deficiency, or immune activation and mTOR inhibition. So they're not quite as clean. Now, again, this is hard to see, but I mean, it just tells you one thing, that really we knew, even though we knew a lot of this stuff, a lot of this really interesting translational basic science, as much as 15 years ago about triple negative breast cancer, really the standard of care in 2018 and up to probably about 3 or 4 years ago, pre-pandemic, was really chemotherapy. And this is the NCCN guidelines that are used in the United States. But basically, this is it. And I'll go through a few of the trials to show you. But really, all we have, and really in an era where we have targeted agents, and a lot of the world, actually, where many of these targeted agents are not paid for, this is how people manage triple negative breast cancer, generally with a taxane, a platinum, or an anthracycline. We have combinations of these therapies we use, with expecting a median progression-free survival about 4.5 months, a median overall survival of 12 to 18 months. Second line, we have capecitabine, usually available most of the world. Eribulin is not, actually, interestingly enough, expecting a PFS of about 3 months and an overall survival about 8 months. And third line, we give whatever wasn't given. And fourth line, maybe exabepiline if the patient makes it that far. So that's kind of where we were. And I'll just show you a few of the trials that kind of led the basis of this. The first one was a very interesting trial, the TNT trial, which really looked at triple negative breast cancer, of which probably about a third of the patients in this study had BRCA 1 or 2 mutations, germline mutations. They were randomized to carboplatin or docetaxel. It's interesting, we knew carboplatin actually from data from the National Cancer Institute from 30 or 40 years ago. In first line had a response rate of about 31%. In second line had a response rate of about 8%. So it's a really interesting trial to do here. But it was really looking at carboplatin or docetaxel up front. And the bottom line is that, interestingly enough, that all patients, there was really no difference between carboplatin and docetaxel in terms of objective response. However, in the patients that had a germline BRCA mutation, let me see if I can kind of show this up here. I think this works. There we go. That had a germline BRCA mutation, with platinum, the response rate was doubled. And if you look down here, comparing the two in the mutated patients, you actually had an improvement of about 2.5 months, or about a 50% improvement in progression-free survival. If you were not mutated, you had no benefit, and in fact, in some cases, a detriment. Now, we said, oh, maybe this is DNA damage repair deficiency. Well, it turned out, by HRD scores, there's a lot of HRD assays that are commercially available, or even lab derived, but HRD did not predict the benefit to carboplatin in this data. So this led to a lot of work with carboplatin, most of it in the adjuvant setting, which we're not really going to talk about tonight. But one trial a lot of us were involved in was actually sponsored by Abraxis Pharmaceuticals that was acquired by Celgene, and Celgene was acquired by someone else. And so they abandoned this after the randomized phase 2 part of it. But actually, we looked at various combos in triple-negative metastatic triple-negative breast cancer. I mean, these are the kind of trials we used to do before we had targeted agents. So this is a simple trial of nanoparticle paclitaxel with carbo, nanoparticle paclitaxel with gemcitabine, or gemcitabine carboplatin. And this just shows you the results. The gem carbo, actually, interestingly enough, you can see down here, really was the worst. And I don't use combos a lot, and I'm not a big fan of gemcitabine carboplatin when you use chemo regimens as backbones, because of trials like this, even though it's a randomized phase 2, really where the benefit appeared to be were the patients getting nanoparticle paclitaxel and carboplatin. And so that's kind of the other thing that we had. Some other things, that was the first line therapy, maybe combinations with nanoparticle paclitaxel and carboplatin we would use, if not a single agent. But also, interestingly enough, there are trials of eribulin versus capecitabine in the second line setting. And eribulin actually had, if you look very carefully at those red arrows, you can see it had in patients that were triple negative, had triple negative metastatic breast cancer in the second line, there was a benefit in terms of progression-free and overall survival. And so, at least in our practice, we tend to use eribulin second line. This is before, again, we had any of the targeted agents. We would generally use a taxane or taxane combination first line and eribulin second line based on these data that we have. Now we start to get into other targeted agents. The first real targeted agent in triple negative breast cancer turns out to be PARP inhibitors. And I think we're all very familiar with how PARP inhibitors work. They block basically the repair PARP, repairs single-stranded breaks in DNA. PARP inhibitors prevent that from happening. And then when the cells try to proliferate, they get double-stranded DNA breaks. And the DNA damage repair pathways, which are really involved with BRCA1, BRCA2, PALB2, RAD51. If you have mutations in any of those genes, you basically cannot repair the double-stranded break. And as a result, the cells die because the chromosomes can't repair themselves. So that's the idea of synthetic lethality. I think most people are very familiar with it. What's really interesting, though, is that PARPs, and I'll just kind of get into this briefly, it's not really in the slides, but PARPs have varying degrees of the ability, PARP inhibitors, of trapping the PARP against the DNA so it can't move. And so it turns out some are more potent than others. In breast cancer, though, even though some are more potent than others, as you're going to see in a minute, there's really not much of a difference in their clinical efficacy. But there's a whole new class of drugs that are being developed now called PARGs that inhibit the glycosylation of the PARP that are being now used as second-line agents, or in fact are being developed even to become first-line agents. That's kind of where this is going, at least in triple-negative breast cancer and other cancers. But to look at kind of why this became the first real targeted agent in triple-negative breast cancer, we go back to the Olympiad trial. And this is really hard. I mean, it's very difficult to recruit because these patients are not very common. Metastatic triple-negative breast cancer, obviously, is 15% of all breast cancers. And then maybe 30% of those patients will relapse. So now you're down to 5%. And then maybe of those 5%, maybe 20%, have a BRCA1 or BRCA2 mutation at the germline. So now you're talking 1% of all breast cancer. So it's very difficult to do these trials when only 1 in 100 patients are really eligible at the beginning. And then people are reluctant to do clinical trials. So it gets even harder to do. And so this is really a massive effort. Mark Robeson led this from Memorial Sloan Kettering. It was an international group, 125 centers in 20 countries for 302 patients. This really had to be a huge effort. And it took patients either with ER-positive and or PR-positive disease, triple-negative breast cancer, that had to have a deleterious or suspected deleterious germline BRCA mutation. And this is really important because it turns out a lot of times when we do germline BRCA testing on patients, they turn out to have variants of unknown significance. And it's always a question when a patient comes in with metastatic triple-negative breast cancer that has a germline BRCA mutation, and it's a variant of unknown significance. What do you do? And generally, it turns out, I'll tell you, that the vast majority of VUSs turn out to be benign, at least at this point in time. So it's really interesting. I don't think the insurers, at least the United States, the way insurance payment works, I don't think they're sophisticated enough to know that a VUS really shouldn't be treated, was not included in the Olympiad trial. But it's a really interesting clinical conundrum I think we're still trying to figure out. But nonetheless, the patients are randomized 2-to-1 to olaparib, which is the PARP inhibitor, or standard chemotherapy that would be used. And about a third of the patients had a prior cisplatin in either the adjuvant or the metastatic setting. This shows you the data, which I think most of you in this room may be familiar with. But the bottom line is that there was a progression-free survival advantage, a hazard ratio of 0.58, which was significant, as you can see here. The overall survival, however, was not. So you got kind of a brief kind of benefit here, although I think, out of 12 months, there still was a fairly substantial proportion, maybe 30% of the patients on olaparib that did not progress in the first or second line, but there was no survival advantage. However, when the data was looked at a little bit more carefully, and if you go delve into the papers, and there's a publication in Annals of Oncology about 4 or 5 years ago, if you had olaparib could be given in the first or second line for metastatic disease. And what you can see here, if it's given in the second line, there's no survival advantage. But given in the first line, there may be a survival advantage. It's just the N was so small. You can see here the p-value is 0.02, and it's kind of the numbers of patients in this trial, 59 versus 28. You can't really make a lot from this data. But on the other hand, it suggests maybe that we should be using PARP inhibitors first line for triple-negative metastatic breast cancer that's BRCA germline positive. Now, in an era of antibody-drug conjugates, I'm not sure the relevance of this data, but nonetheless, this is here. The toxicities generally, I think we're very familiar with these agents, are really myelosuppression. There is more nausea, but generally anemia, I think, is the biggest one that we have. I think you really have to watch hemoglobin when you use these drugs. And again, it really hasn't happened in breast cancer. It's happened in other cancers that are BRCA associated that have used other PARP inhibitors. There was a small risk of myelodysplasia and leukemia with these drugs, but we haven't seen it actually, as far as I know, in breast cancer in the trials that we've done. Now, again, talazoparib, as I said before, binds to the PARP better than olaparib. And so this is a trial actually of talazoparib, which is a similar part of talazoparib versus physician's choice of chemotherapy, very almost identical design, 431 patients in 16 countries and 145 sites. So again, to do these large phase 3 trials in BRCA germline mutated patients is very difficult to do, but nonetheless, roughly the same results. A hazard ratio, it looks like, of about 0.5, 0.6, and overall progression-free survival advantage of about 3 months, not huge. And it really didn't matter, how many regimens you had. Basically, there was no subgroup that didn't benefit. In particular, the patient with a history of CNS metastatic disease. I think this is really important that these drugs do cross the blood-brain barrier and can be used in triple-negative breast cancer with brain metastasis, and we do use them. However, there was no survival advantage. And one idea is that maybe there was a crossover in the platinum arms here. What you can see here is fully in the chemotherapy arms. You can see here that about a third of the patients got a PARP inhibitor afterwards, a second-line therapy. So this crossover may have resulted in no final overall survival advantage for the PARP inhibitor here. So that was the first targeted agent, and actually it did get approved in metastatic triple-negative breast cancer. I think that one thing I didn't show is how best to use PARP inhibitors, and I think it's still a matter of debate. What I didn't put in this, in just the interest of time, was a trial called Brocade, and it was with a weaker PARP inhibitor, olaparib. And it was weak enough that it could be given with chemotherapy. So it was a trial of carboplatin, paclitaxel, and olaparib versus carboplatin and paclitaxel. And it turns out there was a progression-free and overall survival advantage to the olaparib, but it only occurred after the chemotherapy stopped. So the curves were similar. And then when you stop the chemotherapy, the patients that remained on olaparib, had maintenance therapy, actually began to have a progression-free and overall survival advantage. And that mimics what we do in ovarian cancer, right? Ovarian cancer, you use the carboplatin and paclitaxel first, and then you give the PARP inhibitor as maintenance. And we really don't have any maintenance trials. We never had a lot of maintenance trials in metastatic triple-negative breast cancer. I think there's one or two that may or may not announce in the not-too-distant future, but I think that may be the way to use PARP inhibitors, is not necessarily as treatment like we do it now, but rather as maintenance after achieving some sort of response with, say, some sort of agent, like I'm going to talk about in a minute. So the other major kind of thrust, at least initially, for triple-negative breast cancer for target agents was immune checkpoint inhibitors. This is the Keynote 355 study. I think many people are very familiar with. It was presented a while ago. Again, these are patients that had varying levels of PD-1/L1 expression on their tumor. It's really more in the tumor microenvironment. And if you had a CPS score of greater than 10, your benefit here, as you can see here, the hazard ratio was about 0.65, and it did have benefit for the patients who received checkpoint inhibitor with paclitaxel versus paclitaxel alone. And that was in about 38%, 40% of patients had a CPS score of 10 or above. And it actually had a 6.9-month increase in overall survival. So actually, interestingly enough, the same result was seen in the PD-1 inhibitor, atezolizumab. But because of the statistical design of the trial, the results are almost the same. Because of a statistical quirk in the design, it was not approved by the US FDA. In fact, it was taken off the market. It was marketed and they withdrew it from the market because they actually had pembrolizumab instead. And so pembrolizumab, at least in the United States, is now the standard of care with paclitaxel for patients in first-line triple-negative breast cancer with a CPS score of 10 or greater. Interestingly enough, looking at this, it's actually interesting. You can actually look at the progression-free survival and overall survival and look at them based on the CPS score. So the degree of staining for CPS, mostly in the tumor microenvironment for PD-1/L1. And you can see that you begin to get the survival advantage when the CPS score is greater than 10. And in fact, you get the advantage when it's greater than 20. And I'm going to get to that in a minute because I think that's really important. The biggest problem with these drugs, however, and it really has, in the metastatic setting, it's not as much of an issue because women really are trying to do anything they can to gain an overall survival advantage. But in the neoadjuvant setting where these drugs are really used, we're really not going to talk about that this much in this presentation. But the biggest problem are the immune-mediated adverse events. And the biggest one, I think, in women is hypothyroidism. In this trial, about 15% of the women had hypothyroidism from the immune checkpoint inhibitor. And why is that? Because it turns out, I'm a closet endocrinologist. I almost went into endocrinology. And it turns out that women in their, who would be getting these agents, if you do anti-thyroid antibodies, you get about 15 to 20% of women have asymptomatic immune thyroiditis. And so all you're doing is removing the checkpoint on that, and you're getting the immune thyroiditis in these women, either hypo or hyperthyroidism. There is a little bit of pneumonitis, a little bit of colitis, a little bit of skin rash. There's actually, not in this trial, but in some other trials, there are adrenal insufficiency that you can get that can be permanent. So these drugs are not without side effects. But I think the big one, it really is hypothyroidism. But what I want to show you here, if you go back, and I'm going to go back to a trial that people really don't talk about that much. And this is a trial called Keynote 119. And Keynote 119 was a very interesting design. It took women who had recurred on either one or two prior systemic treatments, usually chemotherapy, for metastatic breast cancer. And they were stratified by PD-1L status, PD-1L1 status. And about 600 patients were randomized to chemotherapy or single-agent pembrolizumab. And this is second and third line therapy now with pembrolizumab. And they were followed for survival and safety. And you can see here, typical distribution, about 30%, 40% had, or 40% roughly, 48% had a CPS greater than 10. Of that, almost 20% actually in both arms, 18.3% had a CPS greater than 20. And why is that important? Because in the CPS greater than 20 patients, there was a survival advantage to single-agent pembrolizumab. So it turns out maybe the more PD-1L1 staining you have on a tumor, potentially even single-agent pembro can work. And we do know that. We know if you have tumor mutational burden, which I think you guys probably do in Australia too, if you do next-gen sequencing, if the TMB is greater than 10 mutations per megabase, pembro is approved as a first-line agent, a second-line agent, at really any line, for just about any cancer, as long as the TMB is greater than 10. And so, it's really interesting. We're trying to figure out whether we, again, the Keynote 109 specimens are gone. The biobank, I don't even know if it exists anymore. But nonetheless, it'd be really interesting to see if those CPS greater than 20 patients actually had high TMB as well, resulting probably in this benefit. The answer is just we don't know. Again, this is progression-free survival. Really, the overall, as you can see here, the response rate was higher, the higher the CPS score you had, which again is very similar to tumor mutational burden as well. So really, what do we do now? Because both are available in the US and are paid for. I think if you have someone that comes in with metastatic triple-negative breast cancer, generally, if the CPS greater than 10, we give pembrolizumab and chemotherapy first because there clearly is a survival advantage for all patients. I think that second-line pembro is intriguing. I don't use it for CPS greater than 20, but if the tumor mutational burden, we do next-gen sequencing in just about everybody now with metastatic triple-negative breast cancer that we see. And if the tumor mutational burden is greater than 10, we would think about giving single agent pembro. We would not give it for a CPS greater than 20, although I'd really think about it, at least in the US. I probably couldn't get it paid for, but I probably would do it. But what do you use first? I mean, it's hard to know. I think that all comers, the IO trials had an overall survival benefit the first line, where PARP did not. And I think that we have maybe IO benefit for second line therapy, but not first. And so generally what we do in the United States is we give immunotherapy plus chemo first line and a PARP inhibitor second line if we have both available. So now we get into some of the newer therapies. Newer therapies really involve antibody-drug conjugates. This is really the third thing, the third movement of targeted therapy. The fourth may be AKT inhibitors that I'll briefly mention at the end. But I think that this is all really important, these newer therapies. And the first one obviously was sacituzumab. Was FDA approved actually for second line and beyond. This slide is an old slide. And sacituzumab, I think, again, is the idea behind these antibody-drug conjugates are to deliver small amounts of chemotherapy directly to the tumor. And again, I think most of us in the room know that with an antibody-drug conjugate, we're interested in four things. What the antigen is, and in sacituzumab, it's TROP2, which is trophoblast antigen. It's present on 96% of triple-negative breast cancer. We're interested in what the payload is in the case of sacituzumab. And most of the payloads, at least for the initial kind of series of antibody-drug conjugates, at least for breast cancer, involve using topo-1 payloads. But in this case, it's SN38, which is a derivative of irinotecan. And we're also interested in the linker. And the linker in this case is a hydrolyzable linker that is hydrolyzed in situations of low pH, which is in the lysosome or in the tumor microenvironment. So remember, an actively growing tumor, necrotic tumor, a lot of glycolysis going on. And as a result, very acidic pH in the extracellular space. And as a result, you can get cleavage and potentially bystander effect, where cells that maybe don't internalize or bind the sacituzumab actually get the localization of the payload to the tumor and maybe kill the tumor as well. And so the idea behind sacituzumab is that the initial trials, which I'm not going to show you, the phase 2 trials in the United States, the initial phase 2 trial was published, I think, in 2019 in the New England Journal of Medicine. And it was a trial of, I think, 110 patients with third-line metastatic triple-negative breast cancer. So these are patients with a survival of like 7 to 8 months. And these patients received sacituzumab at a dose of 10 mg per kg, day 1, day 8. And in that trial, there was an overall survival of about 11 to 12 months and a progression-free survival of about 6 months, which is really double what the historical control said. The ASCEND trial was going on at the same time. And so the US FDA was going to give accelerated approval. So in the United States, I don't know how it works in Australia, but in the United States, what they do is if a drug looks really, really promising in an area of serious unmet need, at least the FDA until recently, I think they've stopped doing this, they allowed you to get provisional approval on the basis of a phase 2 trial while the phase 3 trial was ongoing. And if the phase 3 trial was consistent with your phase 2 results, then you get full approval. And that's kind of what was going to happen with sacituzumab. They were ready to launch the drug in 2019, and then the FDA did an inspection of some of the plants that made it. And again, Immunomedics, which owned the drug at the time, was a very small company. And so they farmed out. It was all third parties that did all their kind of drug development. And so it turns out that there was contamination issues. And the ASCEND trial, this trial was almost closed completely by the FDA. And the company was losing money. They were going to close. All the investigators got together at a meeting in Miami. and we decided to continue the trial. They had non-contaminated drug. The FDA was fine with it, and that led to ASCENT. And so the ASCENT here is the phase 3 trial of sacituzumab in metastatic breast cancer in patients that had at least two therapies for advanced disease, or one therapy for advanced disease that progressed within 12 months. So these are essentially second and third line patients. And they were randomized to either physician's choice of chemo or sacituzumab. And the primary endpoint of the trial was progression-free survival, with a secondary endpoint of the various overall survival response rate, et cetera. The first thing that we saw in the trial, do we have the results? Yeah, there we go. The first thing is just to talk a little bit about the toxicity of these drugs. The major toxicity really is neutropenia and diarrhea. So about 70% of the patients got grade 4 neutropenia, about 6 had fever neutropenia. Initially, prophylactic growth factors were not required. And even to this day, about half of the patients in the United States getting sacituzumab govitecan do not get prophylactic growth factors. But those were probably the two big ones. It was neutropenia and diarrhea. About 10% of the patients had grade 2 diarrhea, grade 3 or worse diarrhea. About half the patients had alopecia in the trial. The first thing you noticed actually was that sacituzumab had a much higher overall response rate. You can see here PRs were about 31%. So added together was about 35% CR and PR versus 5% of physician choice of chemotherapy. And when you include a clinical benefit, which is stable disease greater than 6 months as well, it's about 45% versus 10%. And so really there was somewhat of a benefit here. You can see here the PFS advantage. The hazard ratio was 0.4, was fairly substantial. And I think generally everybody, about half of the patients progressed at the first scan. I mean, you can see here in the physician's choice of chemotherapy, this is sort of what we see. About half the patients can simply blow through that second and third line chemotherapy, where in sacituzumab, you're actually preventing a lot of that. And I suspect a lot of this, I mean, at least 80% of the patients in this trial had liver metastases. And I think all of us know in triple negative breast cancer, and in cancer in general, I think in breast cancer, is that the two organs, I think, that are really put the patients at most risk are liver and brain. And when you have progressive cancer in the liver, you really have a very short window that you can, especially in a rapidly growing triple negative breast cancer, before a patient's liver begins to fail and you can't give them anything. Suddenly their bilirubin is 5, 6, 7, and you really start to get limited in what you can give people. And I think what sacituzumab probably is doing in this and some other trials that we're not going to talk about is probably preventing the liver mets from really progressing to the point where the patient then has liver failure. I think that's probably what it's doing more than anything, to actually give it a survival advantage. And the survival advantage was doubled. The hazard ratio was 0.48. It was doubled to 12 months. And this is actually what led to a premature stoppage. The trial was stopped after this. The DSMB saw the data in mid-2020. It was presented actually at ESMO 2020 and approved by the US FDA shortly thereafter. And you can see here is a survival advantage that was doubled here. Now, the final data was actually just published in the JCO a couple of weeks ago. And again, the progression-free survival in the final analysis still remained about 5 months with a hazard ratio of 0.41. And the overall survival advantage still remained here. And really looking out here now, this is still some censoring, but a number of patients that are now out here, you can really see a substantial proportion of the patients after 15 months, 92 out of the initial 100, this is almost 40% of the patients are still alive after about 12 to 18 months. So, I think in a selected group of patients with triple negative breast cancer that's progressed through at least one regimen, you really have altered, at least temporarily, the natural history of the disease. The problem is that we don't know who those patients are. That's the issue. We really don't have very good biomarkers. I'm going to show you in a few minutes for response, at least to sacituzumab govitecan. So I think this is one targeted agent. One, I think you can see this better than me, unfortunately. I can't really read it from here. But you can see here that there is potentially, and this is a question we asked was, was the degree of the antigen on the surface of the cancer cells kind of like HER2 and trastuzumab, was the degree of expression important? And it looked like it was. There was a trend here. You can see, if you kind of see, I can't really see these from here, but you can see there's a trend toward improved progression-free and overall survival versus physician's choice. The higher the H-score, which is basically the intensity times the percentage of cells you get for TROP2. But the interaction p-value was not significant So really, we still say, even to this day, that we really don't do TROP2 testing on metastatic triple negative breast cancer because of this. Now, the other alternative drug is datopotamab, and this is a drug I'm just going to show you data for a little bit different indication, just to kind of introduce datopotamab. But there's a trial called TROPION-Breast02 that's in triple negative breast cancer. But I'm going to show you a little bit of limited data, both in ER positive metastatic disease, as well as I'll show you data from at least a phase 2 in triple negative. So Dato is very similar. It's a humanized anti-TROP2 antibody, but it has a slightly lower antibody-drug ratio, 4 instead of 8. The reason for that is that they used 8, it was too toxic, so they had to go down to 4 of the payload, 4 payloads per antibody. But it is a little bit different payload. It's deruxtecan, which is a topo-1 inhibitor, but it seems to be, at least preclinically, one of the more powerful topo-1 agents that we have, better than I think than SN38, and it's given every 3 weeks. The TROPION-Breast01 study, again, was a little different than triple negative. This is actually ER-positive patients that have progressed through at least 1 to 2 lines of chemotherapy after endocrine therapy resistance. So this is like a 3rd or 4th line trial for ER-positive patients. And again, these patients received Dato versus investigator's choice of chemotherapy. And in this trial, there was a small benefit. I mean, a little bit more modest than I think all of us thought. Going from about 5 months with physician choice of chemotherapy to 7 months. The hazard ratio was significant, though. It was 0.63. And really, it didn't really matter. All groups benefited from the datopotamab. Now, there was a higher response rate, 36% versus 22%. But there really was a trend toward overall survival. But really, there was not. The median follow-up was presented at ESMO 2023 was only about 10 months. And I think we're going to have some updated data. I don't think we got it at one of the ESMO Breast or EBCC. I think it's going to be either at ASCO or probably in the fall at ESMO 24 or San Antonio 24. We don't know yet. But this is kind of interesting because I don't know if there's going to be a survival advantage. Because the problem is, as I'm going to show you in a minute, most people may get trastuzumab deruxtecan after if they're HER2 low. But we'll have to see what happens there. The big problems with this drug are a little different. I think the big one is rash. Can be fairly severe. Actually, ocular problems, dry eye, which is almost a conjunctivitis, can happen. It happened in about 23% of patients. I think that it really didn't result in discontinuation of treatment, but I think the big one really was rash. And I think rash was the big problem here. There was interstitial lung disease in about 5% of the patients. And again, ILD is very poorly understood. It has to do, I think, with the payload as well as the antigen that the antibody is binding to, but there was ILD with this drug. Now, the other thing, we all said, okay, this is kind of modest, modest benefit. This is the first kind of TROP2 agent that wasn't sacituzumab govitecan. People really weren't that impressed by it. But at the same meeting, actually, Peter Schmid presented data for use of datopotamab as a first-line agent in a variety. The Begonia trial was really a dose finding and a basket trial. And as you can see here, there are multiple treatment arms of this in the Begonia trial. There was paclitaxel, there was capivasertib, there was DXD, and finally, there was Dato-DXD, as you can see here at 6 mg per kilogram. And I think that what you can see, and so with a median follow-up of 7, basically in this arm 7, there was a dose expansion phase, and with a median follow-up of about 8 months. Let me get back. I'll just show you the response. It's easy to go back. The response rate was 79%. So it's fairly high. And again, this is a first-line trial, not a second-line trial, but nonetheless, I think it's very impressive data, and we're very excited by this. We're waiting now, and again, the toxicity is what we, essentially thought it would be. It's generally the dry eye, stomatitis, rash. But generally, this is actually fairly interesting data. So this is actually Dato plus durvalumab. And I think we're awaiting, actually, the results of the TROPION-Breast02 trial, which is a randomized trial of datopotamab versus physician choice of chemotherapy in the first and second line. And then there also, I think, are another trial that's actually involving durvalumab in patients with PD-1L1 expression with a CPS greater than 10. So this is actually very interesting data, recent data, but again, we're awaiting the TROPION-Breast02. It's not going to be at ASCO, so it's likely going to be probably at one of the European meetings, or hopefully at latest San Antonio 2024 in about 6 months. So hopefully we'll be able to see that. But again, I mean, the data is actually pretty impressive. The median progression-free survival was 13 months versus about, as we saw before in some of the other IO trials, the median PFS is about probably 8 months. So really, you're almost doubling the progression-free survival in these patients, and the duration of response is quite long as well. But again, this is a subgroup analysis. This is only a small part of a larger trial, again, with the biggest problems being stomatitis, dry eye, et cetera. So that's another targeted agent. So we have now TROP2 targeted agents. What about HER2 targeted agents? And so at ASCO 2022, this was presented and published in the New England Journal of Medicine a couple of weeks later, was DESTINY-Breast04. And DESTINY-Breast04 actually used trastuzumab deruxtecan, which is very active in HER2 amplified metastatic breast cancer. Again, TDXD, the antigen is HER2. The payload is deruxtecan, which is a topo-1 payload. It has a cleavable linker, and the antibody-drug ratio is 8. And again, because it has a cleavable linker, there can be release of the payload in the extracellular space with a bystander effect as well. And so DESTINY-Breast04, again, I think most people are familiar with this design, initially was designed in HER2, in hormone receptor positive, HER2 low patients, 1+ and 2+ by immunohistochemistry. They added, during the trial, another 60 patients with ER/PR negative, HER2 low, what we would call triple negative breast cancer as well. So there were 60 patients treated, and it was a randomized 2-to-1 TDXD versus physician's choice of chemotherapy. And again, for all patients, you can see here, TDXD doubled the progression-free survival for all patients and actually improved the overall survival of all patients from about 17 months to about 24 months. And I think that this is, impressive enough. But I think what was really impressive, all these are very, very small numbers, and that's the issue here, is in the triple negative patients. And you can see here's an exploratory analysis. There are only 60 patients total, 40 in one arm, in the experimental arm, 20 in the control arm. But you can see here, you're improving the PFS from about 3 months to over 8 months, almost 9 months, median PFS, and improving the overall survival of the patients, which is about 8.5 months. And again, these are patients in the second and third line therapy to about 18 months. And again, if you remember sacituzumab govitecan in that trial, you can't really do cross-trial comparison, especially because these trials are so small. This is such a small subgroup, but that's about 12 months. And so I think this is really interesting data, what to do. I think, again, the major side effects from trastuzumab deruxtecan, nausea is probably the big one. Neutropenia is not that bad. Alopecia is about 1/3 of patients, but the big one is really interstitial lung disease. And I think that we really have made a big effort now that we're using TDXD very extensively for many indications in the United States. I think we're really, really, really concentrating, especially in the community, on recognition of ILD. And the biggest one is a new cough or shortness of breath, particularly when people are going up stairs or hills. It seems to be what happens. You hear something, yeah, I'm getting short of breath. And we tell women, you must let us know this immediately. Because if it progresses to, and then symptomatic ILD is really grade 2. Asymptomatic ILD is basically a CT scan that shows abnormalities, ground glass abnormalities, or other abnormalities that have developed while on TDXD. That you can retreat. In fact, there was data presented actually at ESMO Breast last week that treatment was successful. I think Hope Rugo presented this. I think they had about 60 or 70 patients that were retreated across all of the trials of trastuzumab deruxtecan. They had grade 1. They were resolved to grade 0, and the patients were retreated. And I think of those 60, I think about 40 to 45 actually were able to be retreated. And many of them responded actually again in the second line. I don't have that data because it's just so new I couldn't make the slides. But I think that's important. But if you get to grade 3, that is to the point where you require oxygen and you're in an emergency room, I think that it's very difficult to reverse. I just found once someone's in the hospital, I think it's very, very, very difficult to reverse grade 3 or obviously grade 4 ILD. I mean, you use very high dose intravenous steroids, sometimes even things like anakinra and IL-6 inhibitors, tocilizumab. People have tried, but it really is very difficult once you get to that. So we really have undertaken a huge educational effort in the United States, especially in the community, because I still get consults now from people. The patient's in the ICU, she has a weird pneumonia. What's wrong? We gave her TDXD a couple times, and people didn't recognize the ILD. So it's really, really important to emphasize this. And I think when doing that, really, at least in this trial, the incidence of grade 5 fatal ILD was about 0.8%. But in some of the other trials, it's a lot less. The triple negative trials, it's less, because we've gotten used to the ILD and managing it. So usually most of the ILD in these trials is grade 1 or 2. It's very uncommon to get grade 3 or 4 anymore with recognition. So again, I think that I think we actually talked about this as duplicate. Actually, no, this is actually the update. I'm sorry. So this is actually updated at ESMO. And again, this is the updated survival advantage. It still remained an impressive progression-free and overall survival advantage over physician choice of chemotherapy in the triple negative breast cancer patients. You still had, in the updated analysis, a lot less censoring. You can see at 24 months, fully a third of the patients are still alive. And again, this is data, this is using TDXD in HER2 low patients with triple negative breast cancer as second or third line therapy. Now, the question people always ask is, what do you get afterwards? And this is the big mystery. We're in a post-ADC world, and not only in triple negative, but HER2 positive metastatic breast cancer. What do we do? If you've had one ADC, will you respond to another? And right now, the data is mixed. I'm not going to show you any data now, but this just shows you what the subsequent anti-cancer therapies were. And you can see here that this is all the data we have. I think at this meeting, at ASCO in a couple weeks, and I think in the European meetings over the fall and into the winter with San Antonio, we're going to get a lot more data. But there just isn't a lot of at least clinical trial data with this. But you can see here, a few patients got sacituzumab govitecan after receiving TDXD. And there was a little bit of response in those patients, not a ton. But nonetheless, I think that, in terms of toxicity, the toxicity remained the same. There was actually now one extra fatal ILD, but the vast majority of them were grade 1 and grade 2 in this updated ESMO. So again, what do you use? And in fact, I'm not going to present, but others are going to present the Destiny Breast 06, which is trastuzumab deruxtecan in ER positive breast cancer, not triple negative, with HER2 what's called ultra low, even a whiff. So HER2 1+ is faint staining in 10% of the cells or more. HER2 ultra low is any staining of any percent. So that actually, there was a press release. It's a positive study. We just don't know how positive it is. We'll find out in a week and a half. But really, that's an ER positive metastatic population. Really comparing the only data we have right now in metastatic triple negative breast cancer with ADCs, at least with the trastuzumab deruxtecan, really is in Destiny Breast 04. It's very small. It's a subgroup analysis. I think that, again, I think comparing the two, you can see here, I think these trials were a little bit different. The median number of chemotherapy lines, at least with trastuzumab deruxtecan in their trials, was 1. With sacituzumab, it was at least 3, or in some cases 4. So I think that, again, the big issue, and not so much this issue, but I think we have at least 500 patients randomized with sacituzumab to at least the TROP2 antibody, and only 60 for HER2 low. And so I think in the United States, at least, most of us in metastatic triple negative breast cancer that's HER2 low will likely reach initially for sacituzumab. And then again, without any data to guide us, potentially we'll give in the patients that are HER2 low, trastuzumab deruxtecan. Now we'll see where that goes in an era where maybe datopotamab comes in, but that's kind of where we are right now with that. And this just shows you what the guidelines are from the NCCN. This is from a year ago. It really hasn't changed much. I think that first line really depends on your CPS score and germline BRCA mutation. Generally, it's pembrolizumab and chemotherapy if your CPS is greater than 10. If it's less than 10 and you're wild type, you get systemic chemotherapy. If it's less than 10 and you have a germline mutation, basically people prefer a PARP inhibitor or a platinum agent. Second line with a germline BRCA mutation is obviously going to be a PARP inhibitor first. If you don't have a germline BRCA mutation, I think sacituzumab is considered the category 1. And essentially, if you're germline IHC 1+ or 2+, they do recommend trastuzumab deruxtecan, but I think most of us at this point, again, will likely give sacituzumab before trastuzumab deruxtecan. And third line is what we didn't give in the second line. And then we just give single agent chemotherapy. ESMO is very similar in terms of their guidelines, except ESMO really has made the decision for that second line therapy to be sacituzumab, where NCCN in the United States allows either one, as the European guidelines really are sacituzumab, and then if you're HER2 low, go to trastuzumab deruxtecan as therapy afterwards. Again, we have very little data to guide us for these guidelines. This is mostly expert kind of consensus at this point. I don't think we're going to be doing trials, although there are trials of novel ADCs. There's a Ribulin ADC that's specifically in patients that have progressed on trastuzumab deruxtecan, but really don't have a lot of data on that. And so this is kind of where we are right now. I think, again, first line is going to be, if you're germline mutated, is olaparib or talazoparib, PD-1/L1 positive, chemotherapy, and pembrolizumab. I think in Europe, still think you're allowed to give nanoparticle paclitaxel and atezo, but not in the United States, and chemotherapy as a single agent. I think, again, most people in the second line will get sacituzumab. In the third line, if they haven't had sacituzumab, they'll get it. If they've had sacituzumab, they'll get TDXD. That's kind of where we are right now. So I think to kind of summarize a lot of data, I think for PD-1/L1 positive disease, I think, again, immunotherapy and a taxane first line. BRC mutated, we would give PARP. If they're both positive, we'd probably give the IO first and the PARP second. If neither are positive, chemo first and then sacituzumab second. Third line, whatever, they hadn't been given yet. I think after sacituzumab, if the HER2 is low, generally most of us are reaching for trastuzumab deruxtecan and then single agent chemotherapy and beyond. And I'll end with the future. And I just want to focus on just one really important thing here. And that's really this PI3 kinase pathway. So you have the DNA repair deficient pathway, which is not really shown here. I think it's over here. There's a DNA repair deficiency. And we're kind of looking at the various new kind of PARPs and PARGs inhibitors. And I think that hopefully that'll be beneficial, and maybe we'll be able to, like we do in ovarian cancer, expand the universe of who we can give these drugs to in metastatic triple negative breast cancer, not only in obviously germline BRC1 or 2 mutated patients, as well as maybe PALB2 and some of the other mutated patients, both germline and somatic, but actually patients that have DNA repair deficient patients, like we do with ovarian cancer. HRD testing is standard of care in ovarian cancer. In fact, PARP inhibitors are standard of care for patients that have DNA repair deficiency in ovarian cancer. And we really feel that triple negative breast cancer and ovarian cancer are very similar molecularly. And I think it's really interesting that why we're just not getting it. Maybe we're not testing for HRD properly in breast. I don't know the answer, but that's one thing. But really the thing that I kind of mentioned when I started this talk is that in these basal-like triple negative breast cancers, it appears that the DNA repair deficient cancers and the mTOR, PI3 kinase mTOR, P10 pathway cancers are mutually exclusive. Not quite, not 100%, but pretty exclusive. And again, I think that we're really looking forward to the Capitello 290 trial, which again is an AKT inhibitor, capivasertib. It's paclitaxel first line with or without capivasertib for first line metastatic triple negative breast cancer. And hopefully we'll see that. We're not going to see it at ASCO because the abstracts are out and it wasn't going to be presented. Maybe it'll be hopefully in the next year we'll get some data on this, because I think that may give us yet another targeted agent. So there'll be 4 general classes of targeted agents now in metastatic triple negative breast cancer that we never had before. And one thing we never talked about yet, because this was really a metastatic talk, if I did adjuvant, it'd be another hour and I want to keep you here all day. But I think that we're using a lot of these targeted agents now as early stage therapy in both neoadjuvant and adjuvant therapy. I think that the Keynote 522 trial is neoadjuvant pembrolizumab with standard chemotherapy with a pathologic complete response rate in excess of 65%. We now have a survival advantage in BRCA mutant patients with adjuvant olaparib in triple negative breast cancer. So now, the universe is going to be like HER2 positive disease. The universe of triple negative breast cancer patients that are metastatic and recurrent is going to keep shrinking and shrinking, where the vast majority of patients we're going to have are going to be de novo, like it is now with metastatic HER2 positive breast cancer. I think the vast majority of patients are de novo patients and not relapse patients. And hopefully the same thing will happen in triple negative breast cancer now that we have all these new targeted agents. So with that, I'll kind of stop. And again, thank you very much for having me for this keynote. Thank you very much.
So thank you very much, Prof. I'll let you have a bit of a drink and then we'll go to questions.
Fine.
Yeah. So any questions from the audience? Well, there must be some questions. Yeah. Okay, Andy.
Thanks, Adam. So you said as you're coming out of the part of the talk that we had where to go with them in the ADC world is getting hard to know exactly. You mentioned also the olaparib chemotherapy study where olaparib being a weaker PARP inhibitor allowed conjoint treatment. I know there were other trials where it's pretty toxic.
Right.
I think with ADCs, when we talked about them initially in the concept, we were talking about these would be great because we'll get benefits and we'll get less toxicity, but we're always hungry for efficacy, and so we push them all the way up to the same toxicity, more benefit. What about more modest dose of ADC with PARP? Could you damage the DNA more with a modest targeted ADC and then bring the PARP in as well?
I think it's a great idea, or use it as maintenance. You know, maybe give an ADC for a certain set number of cycles, like we do in ovarian cancer, and then come back with maintenance PARP. I think those are the kind of trials I'd love to see. The problem is that, again, I think most of the efforts now, you know, from pharma companies, which are the only ones really with the capital to develop these drugs, are really for the novel agents now, the second generation, third generation PARPs, as well as these PARGs. And there's really not a lot of effort really being expended for maintenance trials. I think the people are thinking about it, giving, you know, because I mean, the issue is that we don't know how many cycles of this drug. We give it to, you know, until people progress, the ADCs usually. I had a patient actually on Ascent who was on, she had lung metastases. She lived for 4 years on it and was getting it literally day 1, day 8 for 4 years. She didn't mind doing it. But on the other hand, I think there has to be some sort of kind of like either a combo trial, which is not a bad idea, because again, topo-1 agents are DNA damaging as well. But I think that, you know, I think I would prefer a design not of a combo. I know people are trying combos, but I would prefer a design of maintenance. I think we could do that. That's how I'd like to see it.
So I think I saw in the ASCO abstracts coming up that there's also a trial of sacituzumab with pembrolizumab. I don't know if that was for breast or bladder though, off the top of my mind.
Well, no, they're doing, so they are. There's a trial Ascent 3 and Ascent 4. So Ascent 3 is first-line sacituzumab versus physician's choice. Ascent 4 is a randomized trial with PD-1/L1 CPS greater than 10 of, I believe it's Pembro. I think it's sacituzumab and Pembro versus physician's choice and Pembro. Yeah, so those trials are ongoing. Yeah.
Andy again, yeah.
Obviously, you talked about the lack of biomarkers, TROP2 possibly, but not a powerful biomarker. You might be able to not give treatment to a few people. And obviously with HER2, we're certainly seeing even in Daisy's trial, we saw this.
With almost 0, right? Yep.
There's a good bit of interest, certainly it has coming out of HER2 positive space, TDM1 in novel molecular imaging PET scanning.
Yes.
With HER2 zirconium and now the more peptides around antibodies. Has there been any of that work in sacituzumab govitecan? Any TROP2?
So TROP2 imaging? Not that I know of. I think it's a good idea. I think interesting though for immunotherapy, I'm sure you're probably familiar with the anti-CD8 imaging. They actually now have a CD8 tracer, which I think is really cool. So CD8 obviously is, you know, is on killer T cells, is on cytotoxic T cells. And people are using that to try to predict immune response. I think it's really cool. But I don't think we have a sacituzumab labeled, as far as I know, a sacituzumab labeling for imaging.
I can't see any hands up. I think it was a very excellent tour through the past, present, and future of triple negative breast cancer. So thank you very much, Bref. Definitely no other questions before we wrap it up. I know it's a Monday night. Yeah, Matt, yeah.
It's a great question. I think that we don't know right now. I think at least in talazoparib, it was probably crossover. And I think we get some hints from patients that are treated in the first line. There's a hint, even though it was kind of very small numbers from the olaparib studies, that the first line patients had an overall survival benefit, but the second and third line did not. So you're developing some sort of resistance to everything. Maybe the patients that really blow through everything, just it's either crossover or just resistance to everything probably that develops. And that's a result of that. Although remember, these are done in an era where there was no ADC. And so I think that that may erase all of the benefit anyway of survival. That's going to be the problem now. See, we're in a post-ADC world. And so we're not going to know because we're going to have all these PARP derivatives, now the second and third generation. But all the patients potentially will be rescued with an antibody-drug conjugate that has a survival benefit in the second and third line. So it's going to be really hard to kind of tease out where your survival benefit is going to be coming from in trials in the future. But I don't think the other than crossover, there are no really good theories as to why at this point. I think it's crossover is the only thing we can say it with confidence right now.
And you go.
Here we go. Sure, why not?
With the, you mentioned somatic mutations as well, with the BRCA-like tumors.
Yeah.
Part of the tumors biology is a BRCA mutation. In prostate cancer, it's drug dependent. We're seeing some significant benefits in non-germline somatic mutations. We're not really seeing that, I don't think, in breast. Any sense why that might be?
Well, actually, so it turns out there's a trial, TBCRC 48, that was published in the JCO. I was part of that. Our group was part of that trial. It's a small study. It was a small phase 2 of probably about 60 patients, 60, 70 patients that had either somatic BRCA mutations, germline PALB2, germline ATM, germline RAD51, and actually the response in the somatic BRCA 1 and 2 without a germline BRCA 1 and 2 was actually probably the PFS was similar to Olympia. But again, small numbers, phase 2, it's hard to know. But it's interesting that ATM I thought was going to work, didn't work. RAD51 I thought was going to work, didn't work. You know, the only germline other than BRCA 1 or 2 that worked was PALB2. And so those are the three really, BRCA 1, BRCA 2, and PALB2 are the ones that I would use in the metastatic setting for olaparib. But so there is some somatic data. It's really interesting. I mean, the way a lot of us are finding these mutations now, or at least, well, let me kind of go backwards. We would do next-gen sequencing on everybody. It would come in either liquid or solid next-gen sequencing on every triple-negative breast cancer patient that comes in. And we were finding, you know, if the allele frequency was like 30, 40% BRCA2 or 1, we would go back and reflexively germline sequence them now. In the United States, everybody with triple-negative breast cancer in the adjuvant setting now, early stage setting, is getting germline BRCA tested or germline panel testing, not just doing BRCA 1 or 2, because it's just as expensive to do a panel. And so they get all their mutations up front. It turns out that the American Society of Clinical Oncology and the Society of Surgical Oncology came out with a position statement in January suggesting every woman with breast cancer, early stage breast cancer, should be germline tested. So now it's going to happen. So every patient is going to be germline tested. We're going to know we're not going to have to worry about somatic mutations anymore because they're going to be tested up front. Now, again, you could have a somatic mutation develop in the absence of a germline mutation. And I still think you would get benefit in that case. And I've seen it in my own patients and the ones that I put on TBCRC 48. So you do see some benefit.
Yes, I'm sorry, I don't know your name. Yes. Yeah.
So just to take us back, not in the metastatic setting, in the IE setting, once they get the neoadjuvant treatment, and then whether they have complete pathological response or not, is there a role for pathological?
There. It's a great question. And so what we do in the United States now, where this is available, so most people in the United States with a tumor T2 or above in the early stage setting will get the Keynote 522 regimen, which is paclitaxel, carboplatin, adriamycin, Cytoxan with pembrolizumab, expecting a PCR rate of about 65%. If you're germline BRCA mutated, So, and we also give another 3 to 4 months of pembro, whatever, to complete a year of pembrolizumab afterwards as a single agent. In the United States, what a lot of people are doing, if you have a germline BRCA and 1 or 2 mutation, is give adjuvant olaparib if there's not a PCR. So if there is a PCR, we just continue the pembro for the year. If there's not a PCR, the standard of care really in the US right now is to continue the pembro and give capecitabine. It's not a lot of data to support that, but that's what people do. If they're germline BRCA mutated, because there is a survival advantage to adjuvant olaparib in patients who do not have a PCR to neoadjuvant chemotherapy, we would give adjuvant olaparib. And the question is, do we give it with pembrolizumab or not? Most US oncologists are giving them together. That's kind of real. I'm not sure that's wise personally. I don't really like to do that myself, but I definitely think the olaparib in that setting would give more benefit than more adjuvant pembro. That's just my opinion. We're going to have data on adjuvant pembro relatively soon. So it's a great question, but we give both. The short answer is if you're germline BRCA mutated, you get both. Interestingly enough, there's a trial called Olympian. I don't know if you guys participated in the international phase 2. It just finished. It's about 80 patients with germline BRCA mutations, BRCA1, BRCA2, getting single agent olaparib, nothing else. And it turns out from prior studies with talazoparib, the PCR rate to single agent olaparib given, or single agent talazoparib given for about 4 to 5 months was 60%. It was the same as chemo with a lot less toxicity. So obviously that's going to form the basis of a large phase 3. It's probably going to be the Keynote 522 regimen against neoadjuvant olaparib. So we'll see what happens.
One last question.
Oh, go ahead.
What's the mechanism of this patient getting neutropenia and he gets the ADC?
From the ADC, why it's getting neutropenia? It's cytotoxic because basically what's happening, as Dr. Redfern kind of hinted at, a lot of people have said there's just a way to give, continuous low dose, metronomic chemotherapy. That's where, you give someone low dose DXD and maybe get the same result. I'm not sure I potentially buy that because I suspect some of the mechanisms of resistance actually have to do with antigen downregulation or a mutation of the receptor potentially. So if you're starting to see those mechanisms of resistance, the antibody has to be doing something. But on the other hand, as Dr. Redford mentioned, we kept pushing for efficacy. So as a result, you're starting to see some of the typical topo-1 side effects, which are neutropenia and anemia. So that's what it's really just because you pushed the dose so high. I think because you had to. I mean, you're kind of balancing efficacy, with toxicity. And I think the way at least the trastuzumab deruxtecan trials were done was really they did 5.4 milligrams per kilogram, 6.4, and 7.4, something like that. They had a lot of tox at 6 and 7, so they settled on 5.4. What they didn't do is go lower. Why didn't they go to 2? They never did that. They really they started at 5, 6, and 7. Where's the 1? Where's the 2 for efficacy? You probably should have done it that way. And who knows? I mean, they may have preclinical data that was guiding them. But I think maybe we are giving a little bit too much drug. And I think we'll probably have some real world data in the not too distant future on dose reduction. We do know with a lot of the targeted agents, if you dose reduce them, like ER positive disease, CDK4/6 inhibitors, you can give less and still get the same benefit. Not pembrolizumab, there are other agents that you can reduce the dose and still get the same benefit with targeted therapy. So I think that real world data is going to help us with that. That will probably have a lot of people treated with both sacituzumab as well as trastuzumab deruxtecan and maybe datopotamab if it gets approved. And we'll see, because a lot of those people will be dose reduced for toxicity. And so we'll be able to see efficacy data from the real world, probably not from clinical trials, but actually from the real world data. It's a great question. Yeah. We're going down into tamoxifen. We're going down, and I think it's de-escalation. We're kind of trying to de-escalate everything.
It is something I've actually found very surprising in oncology trials. And I know they do dose finding and dose escalation studies initially, but I do feel like the dose we often use to start with is usually still reasonably toxic. And then we always pull back. Why don't we, start in the middle and move up? But we don't seem to do that.
I think they're afraid. I think they're afraid of missing. I think the sponsors of the trial are afraid. All of us are afraid of missing an efficacy signal. And it's always a balance. And I think the way things will be done is that we'll kind of get that balance. Then during the trial, we'll look at the subgroups that were dose reduced and see if there's a benefit still. And then maybe then compound that with real world data to justify the lower dose. I think that's how drugs will be developed. It's just the way it is. I think in oncology, we don't want to miss efficacy if we
Yeah.
can. I mean, Andy said the same thing. It's kind of like we're chasing efficacy so much, that we kind of forget that these drugs are fairly toxic as well.
Okay, Andy, I'll make that the last question then as well, all right? Yeah.
We've had discussions a bit about it. DPD testing was capecitabine and UGT1A testing.
Yeah. Right.
Are you doing that routinely in the US?
So no, I'm not, but I'll tell you, I had a patient actually came to me as a consult who got severe neutropenia because it's so uncommon, the UGT1, at least in breast cancer patients. And I think that, and she was UGT1, she was a homozygote for it. And that's probably why she had the neutropenia. So suddenly it's the first patient I've ever had now in my practice. It's had that. So it's kind of woken me up. I may start doing it a little bit more, I think. DPD, we don't do routinely for CAPE.
Even if they had a raised bilirubin and you were suspecting Gilbert's, you wouldn't even start dose reduced again,
I would think about it.
Yeah. All right. Well, thank you very much, Dr. Brufsky, for coming all this way to Australia. I know you've got a bit of a tour around the rest of Australia coming. So thank you very much again to our sponsors, and thank you for everyone for attending tonight. I'd just like to remind you all again that you will get an evaluation form. I know, again, it's a Monday night and you probably want to get to bed and you've got work tomorrow, but please do fill them out because it does help us with planning future events. Okay. Thank you.